Thank you for registering and connecting to today's webinar on the topic of the built environment of the hospital and nosocomial infections, sources and transmission routes. This is a very timely topic at a time when we're seeing an increased number of nosocomial infections, including not only bacterial, but fungal pathogens. And most troublesome has been the rise in the multi-drug resistance among bacteria and fungi. This is the second webinar that is held jointly between the International Society of Antimicrobial Chemotherapy, ISAC, and the European Society for Clinical Microbiology and Infectious Diseases. The first webinar was on the topic of AMR in displaced population. I need to mention that the content of these two talks today were presented in the ICC 2024 in Istanbul. But because the topic received a lot of interest, we felt that it was important to bring this in the form of a webinar for those who could not be with us in Istanbul to attend this important symposium. My name is Souha Kanj, and I'm a professor of infectious diseases and the chair of the Infection Control and Prevention Program at the American University of Beirut Medical Center in Lebanon. And I'm also the co-chair of the Antimicrobial Stewardship Program. And I'm currently president of the International Society of Antimicrobial Chemotherapy and president of the Lebanese Society of Infectious Diseases and Clinical Microbiology. I have the pleasure and honor to be co-chairing this symposium with Professor Robert Skov, who for many of you does not need a big introduction, but just as a summary, because we don't want to spend the whole hour and a half talking about his achievements, but Professor Skov is currently president of the European Society of Clinical Microbiology and Infectious Diseases, and for many years, he was lead of ICARS. He is a professor of clinical microbiology in Copenhagen and has done impressive work on methicillin-resistant Staph aureus and infection control and prevention and on epidemics. So I'll leave the floor to Professor Skov to introduce the first speaker. Robert, the microphone is yours.
Thank you very much, Souha, and thank you very much for the very nice introduction. And just want to start to say that it is a huge pleasure for me to be representing ESCMID here and together with ISAC, giving this a really important webinar here. So today's first speaker will be Professor Margreet Vos. Margreet is a clinical microbiologist, and since 2012, she has been the professor of healthcare-related infections at the Erasmus University in Rotterdam, the Netherlands. She is a member and chair of many international committees and working groups, both on infection prevention in general, as well as on MRSA. And for many years, he initiated as well as chaired a national working group as part of the Dutch Society of Medical Microbiology, where she initiated, developed, and chaired the Committee of Infection Control National Guideline on the organization and quality of hospital infection prevention. She's currently a member of two international guideline committees, the ESCMID-HIS guideline on behavior and rituals in the operating theater, and the ESCMID-UKIC guideline on multi-drug resistant gram-negatives. She's furthermore a very experienced researcher with more than 230 publications, and it's therefore really a pleasure to give the floor to Margreet to give the first talk. Please, Margreet, the floor is yours.
Thank you very much, Phil. And my talk will be about hospital design matters, especially in a case of infection prevention and control. And I have no disclosures except my department. You can see here my mouse. My department is here, and it's in the middle of a large university hospital, which is here, and it is built in 2018. The old hospital was here, so nearby, and here's still the old children's hospital. And my disclosures are that we were very much involved in the design of this new hospital. So what about the design? A microbiological safe hospital. What is that? Well, it means exactly that in a microbiological safe hospital, we will break the chain of transmission where the environment is involved. You all know that we have colonized or infected hosts with AMR or just sensitive microorganisms, also possible. And this can become a reservoir or source in the hospital environment. And in that way, it can be a source for the next patients and so on. It can be by hands, it can be by materials, it can be everything. So we have to break this chain, and especially where the source is in the environment. So how will we do that? Well, we first go back about nearly a year ago now. There was a WHO meeting in October 2024. And the participants were asked, are you convinced that within 10 years we will make considerable progress in combating AMR? And the answers were nearly half of the participants say, well, we are not convinced. We will not make this. So I was thinking about, because there was no questions, why do you think, why are you not convinced? But to my opinion, this is an important part of it, that maybe people think, well, we will not have considerable progress. As part of the AMR prevalence is explained by transmission within hospitals. We all know that a lot of AMR transmission occurs within the hospital during hospital stay. And the next thing we know is that the well-designed hospital-built environment prevents transmission. And so we can do something about this. And we also know, and that's a difficulty, that hospitals are being built for many, many decades. So when building a new one, you try to think more than 50 years in future, what will happen in future. Hospitals are complex, and design should allow flexibility of use because patient population change, microorganism change, pandemics, etc. And well, another difficulty is there is no standard. There's no book reading how to build a hospital with respect to our profession, infection prevention. There is something, the AIA and the American Institute of Architects in the USA, and also the UK has technical memoranda documents which can help you. But there's no guideline. There's no international statement on how to do this with respect to our infection prevention and control. There, of course, there are documents, and this is one example of it, about the built environment. It's written about the core components for effective infection prevention and control. It is published by the WHO 2022. And it says, well, it is all about, or not all about, but it's also about the environment. And it says, well, what is the target audience? Well, these are the leaders, political, government, and healthcare leaders, and the infection prevention control people, of course. So they address these people and say, well, the environment is an important factor in transmission, and we should combat them. But the thing is, to my opinion, that is in this document, I could not find any architects or engineers involved, and they should make it for us. So if we think this is an important subject, we should be in contact with architects and engineers, because they have to understand us, what we mean, and they have to design it in a way we like it. So what can we do about discussing the effect of the design of a hospital on prevention? Well, there's a lot to do, but today I will only talk about the configuration of the hospital wards, the flow, goods and persons, sinks, ventilation, single rooms, and flexibility of the hospital itself during endemic and pandemic. And I will start with the lowest one, not to confuse you, but to keep you awake. So flexibility in design. What is flexibility? That's about adaptability, convertibility, and expandability. And it is about the building. It's not about the people, but about the building. And the pandemic, we all learned that we had to adapt a new way of work organization, routes, entries, people come in, people go out, they stay somewhere in cohorts, in waiting areas, they come to the emergency department, and we have to organize their ways. And so we have to adapt the built environment to do so. We also had to convert convertibility general departments into ICUs because we need more ICU beds. So departments should have a certain level of convertibility. We also had to expand hospital buildings to treat the high volumes of infection patients by doing triage, like in the emergency department. And this picture is from our emergency department, where we put a new building or an extra building for receiving patients with suspicion of COVID. So expandability is important as well. Well, these three items are important to keep in mind when discussing with architects how to design a hospital. And this is all for the near future, because a new pandemic will come for sure. Some words about flow of goods and persons. Well, important to realize that decision on configuration of the flows, so routes, transport routes, elevators, and etc., are mainly based on productivity and efficiency, and not on microbiological safety. So we have to put our opinion to the designers. And we said, well, we learned from the pandemic that transmission occurs in crowded environments with vulnerable patients because they come all together in a hospital. Large number of persons, like in outpatients, daycare, outpatient clinics, waiting rooms, etc. So it's important to realize, and mostly it is, but you have to say that it is important that these places are situated at the base ground, because then you avoid elevators for patients to stick together in one elevator to come to their place where they have to be. And waiting rooms should also be connected to large open spaces, like most hospitals have spaces for social meetings, terraces, etc. So here in this picture, you see an example of our hospital, that this place can be used as a waiting area in case of a pandemic. But then the outpatient clinic must be nearby these kind of spaces. So when the architect is going to design the hospital, you can ask for this and say, well, keep in mind, because we will need it definitely in the near future. So what about corridors? We have a lot of corridors in the hospital, and corridors should be designed so to be able to keep social distance. We learned about that. And this left picture is published in 2013, and they say, well, you have to be able to transport a person and a bed together. And so there was a distance, corridor distance of 1.5 meters. But now it was published in the early days of the COVID that the corridor should be wider to be able to pass with social distance in mind, 2 persons together. So, and square meters is money, so you should be very early in the process of designing the hospital to say that you want to have the corridors at a certain distance, so to keep the social distance. So what about in the WHO technical brief called Hospitals of the Future? It says something about that, particularly on routes and configuration. It says separate and dedicated lifts are needed for waste, clean supplies, food, patients and visitors, and it should be carefully positioned within the functional design. But it also says that functional design is fundamental, and it should be able to separate different hygienic departments and distributing all kinds of flows. Well, to my idea, it's not very clear what exactly you can take home and discuss with your architect. But my comments on this about separate corridors for different clean and dirty materials or patients, I think it's not needed because when you pass each other in a corridor with sufficient width, it's not a great risk for transmission. And also infected patients, known infected patients are already transported with protecting measures. and supplies, waste, etc., is always contained in boxes, and it should be closed during transport. So when this taken into account, and of course you have to take care that this really happens, maybe separate corridors are not needed, and that saves a lot of square meters. Some words about separating hygienic wards. Well, if you decide, and I'm pro for this, to have 100% single rooms, as we have in our new hospital, every room can at every moment be converted for contact droplet transmission, because you just close the door and use PPE, and you have an contact droplet isolation. And talking about an isolation ward for isolation rooms with pressure difference, etc., that maybe it's technically preferred, so discuss with the technicians about that in the design phase of the hospital, but also remind that mix patients from different medical specialties on one infectious disease department. And that can be difficult, but I advise you to make your own risk assessment, what is preferred. In our hospital, we had at every department, nearly every department, isolation rooms. So every specialty, medical specialty, has its own possibility to have use of isolation rooms for their patients. But you really have to think about this, what is needed in your situation. So some words about sinks, and especially the design of a hospital sink. Now, we all know now that sinks are a threat for patients by transmission of contaminated droplet from the drain into the environment and then transmission to another patient. And the sinks are full of, in particular, resistant microorganisms, but also sensitive microorganisms. You don't want them, and you don't want to have this. But there are some words to say about a sink, and my first comment is that sinks are indispensable for patient personal care. So patients will also always have a sink for personal care, so you cannot be without a sink. So, but you can think, of course, where is the sink located. So we need definitely sink designs which are dedicated for hospital use, so not the one you have at home. And you also should teach healthcare workers how to use sinks appropriate and what to do with it and what not. And here is quite a useful list already published in 2018, what to do when you discover transmission of pathogens from contaminated sink drains. And first, you should start to separate clean and dirty tasks in the immediate environment of a sink. So that's point one. And then, of course, you should already have done so. Splash guards, barriers installed directly on both sides of the sink, so splashes cannot be transmitted to the environment. You also need dedicated storage space more than 1 meter from the sinks. So if there is splashing, then it cannot reach clean storage material for the patient. And you should use a sink design which reduces splashes. And when you do this within the red box, and you still have transmission, then you can think about drain covers, hopper covers, heater vibrator units, ozone water, etc., etc. So more the technical stuff, and even try to disinfect, which is quite difficult. About the design of the sink, and that really matters. And it was nicely studied in this paper by Margreet Vos. And she studied two designs altogether, and she had a carbapenem-resistant Enterobacteriaceae, and she measured the splashing from droplets with the Enterobacteriaceae in the immediate environment. And it showed up that when the drain was at rear, then it was better results, less splashing in the immediate environment. And then in another paper, she went on with experiments using this drain at the rear, and then also another designed sink, which was a larger sink area, and it was also with a hydrofin, which caused that the fluid was smoothly flowed, transported to the rear, and it will, and then it turns out that when having a hydrofilm and that larger sink area, there was less splashing around in the immediate environment. So we don't know yet what is the best design sink for patient use, but we know now a lot you can do. So this is a nice overview, also published in 2018. So what's new, you say? Well, when a ball, shallow ball, like less than 19 centimeters, were more likely to disperse, in this case, fluorescent gel. And so there are more features of a sink design which can help prevent splashing into the environment, but these were not significantly. But we definitely need more research on the specific design which can prevent the splashing around the microorganisms with the droplet into the environment. And as we also experience in our hospital, especially in the old hospital, of drains which were contaminated with Vim-positive Pseudomonas. We had a large outbreak. And one of the measures to prevent further transmission of this outbreak were by using drain plugs onto the drain. And that really gave significant results. And we also did that significant results we saw less patients being contaminated, being colonized with the Vim positive Pseudomonas, but we also did experiments with the drain plug, and that significantly showed less transmission from the drain into the bowl, into the sink bowl. So that really helps, and it is a very cheap solution because you can buy it everywhere. So use drain plugs which reduce splashes from the drain onto the bowl. So that is also one measure you can take when you have sinks which causes transmission. So, well, in a nutshell, sinks which you can buy at the construction market are not designed for hospitals because they are just for you at home. And they will always splash from the drain into the environment because the design was not, it was not designed to prevent this. And it is also always possible that you touch the drain. And this is in connection with sewage system, drain pipes, and biofilm. And we all know that the biofilm of a sewage system is full of a hospital microbiome, which is built up from many different users, every few days another user in patient, and also under high antibiotic and disinfectant pressure. And that's why a hospital microbiome is far more dangerous to patients compared to the hospital or the microbiome at your home setting. And that's why you need a special design, because you don't want this hospital microbiome on your body. So we turn to the next subject, that's ventilation. And ventilation is part of the technical program of requirements. And you should be involved in both the functional and the technical program of requirements as an infection control professional. But most data and studies are for specialized rooms or wards, like isolation rooms or operating theater. So there are papers on that, but what about the ventilation, pressure difference, etc. But when we talk just about normal patient room on the general ward, there is not that much. And in this paper, they summarized what was then at that moment, and that was the American Institute of Architects. There were some data from the United States, and there were some data from the United Kingdom. But at that time, only America says something about the minimum requirement of the total air change. There was 6, and the ventilation, so the fresh air, was 2 out of 6. So 4 recirculating and 2 new fresh air for a normal patient. So I'm not talking about isolation rooms in this case. So we have a lot to do still, whether this is enough, it should be more or it can be less, also for sustainability. So also with sustainability in mind, many questions will come to us, can it be less? And that's difficult. So if you want to know what is important about ventilation at the normal ward in the normal patient room, I went back to study what is in the history. And I always like to study in history to understand where we are now. And I ended up with Florence Nightingale. And she's famous, of course. Many of you will know her. And many of you will know her from her book, Notes on Nurses. But she also wrote the Notes on Hospitals. And this is a very interesting book. As he writes, and this is a quote, the very first requirement in a hospital that it do the sick no harm. So we all agree with that, of course. And then she continued, these somber words, of course, apply not only to hospital architects, but to administrators and staff. And we also agree with that, of course, because it's also about implementation and feasibility of implementation. And then she wrote in a private letter, so it was not in the book, and it was a private letter to her brother. And she said, I know no class of murderers who have killed so many people as hospital architects. So that's quite a statement, because she knew at that time already that design matters, you know. And that was in 1889. At that time, she was a very famous invited and also not invited advisor on hospital design. And one of the most famous and known example is the Johns Hopkins University and Hospital. And this is the long list of all hospitals he was involved in the design. And she had ideas about that. And she had especially ideas about the ventilation. Because he said, well, you have to pay careful attention to ventilation. You should separate toilets from wards, and you should separately ventilate the toilets. So that's interesting. And you also have to build a separate building for pathology. So she learned from the Semmelweis issue. And you have to prevent cross-infection by building separate fever buildings. And at that time, of course, it was not known what microorganisms were. But you had fever patients and non-fever patients. And the fever patients, he said, well, they must be in separate buildings. And these buildings have single rooms with own ventilation and a vestibule between the room and the central corridor. So this is the very first isolation room, to my opinion. And in that time, a germ theory of disease was still in its infancy. It was about miasmas or something in the air, so to say. But isolation, they said, well, air in some rooms of the isolation ward first had to pass over heating coils in the basement, so it warmed up, and then caused it to rise, because warm air will rise, through holes in the floor, and the floor of the patient room, and then be pulled up through the patient's private chimney. So it was one floor, and then in the basement it was heated. The air went through so in a vertical way, through the patient room, and then it was expelled. That is very interesting, because it was about flow of the air. And then they said, have this air pass constantly upwards, so that no portion of this air shall be rebreathed or come a second time in contact with the patients. So it was about the patient himself, but also other patients. So that's interesting to know, that they already, without knowing about the real transmission of microorganisms, they knew that passing the air out, it helps. And we don't know about the data, but that was the opinion at that time. And also for the non-fever patient, they also had ideas about ventilation. And so I now come to the general ward. And they said, well, a ward should have windows on one side, and if there is a dead wall on the other, it cannot be healthy. So there must be a flow from air from one side to the other side. So you have to open the windows. And that windows should be tall, very tall, because when it's short, the upper stratum of air does not escape. So you have dead spaces of non-ventilated air with, now we know, microorganisms be there and maybe come back to patients. So that was a very good idea. And here you see a picture of the open wards, which was 30 to 60 beds altogether. You see the large windows which open up, and you see here heating devices in the middle. That was also to turbulate, so to circulate the air to the tall windows to be expelled, to have circulation, but also because the windows were open, maybe it was quite cold in winter. So it's an interesting idea. So, well, back to these days, 2021, the Health Technical Memorandum of the UK say, well, about natural cross-flow ventilation, well, that's possible with a distribution up to a distance of 6 meters, but then you need 2 windows on both sides. And when you have only one side, then you have 3 meters inwards. And when your building is needs more, then you should supplement natural ventilation with mechanical ventilation. And also on places when there is no possibility of open windows or it's inside the building. And mechanical ventilation is expensive, so you should think together with the designers where and when you need it. And then another item on ventilation is the way the air flows. So we had already the Nightingale ID, but this is in a model, and they studied the different pathways of the airflow in just a normal patient room. So it's not an isolation room. And they said, well, this scheme of stratum ventilation is the best one in their model, because it deposits droplets at the initial dispersion state, so immediately with the patient, and it also dilutes droplet concentration at the level of the breathing zone. And then they put into the model what happens when you change or increase the air change per hour. Well, that gives a risk reduction, but they also said it's maybe more important that there's an uninterrupted path of the airstream compared to increase the air change per hour. So it's not just the air change per hour, but also what is the inventory, where is the furniture, etc., and is there an uninterrupted pathway? So that also you should keep in mind when designing the hospital. And the last word in ventilation is about isolation rooms, because there's always a discussion about the door, which kind of door you need. And in this study, that is an experimental study, as you can see here, they compared hinged and sliding doors, and they noticed that sliding door motion induced less air exchange than the hinged door. But also important is that they say, well, the transport of person itself also takes with it a lot of air. So in and out going, so opening the door is important, but going through in and out is even more important than the choice between hinged or sliding doors. So that's also to keep in mind. So some words about single rooms, and I go again back to the history of single rooms, and back to the Nightingale area. So this is after that era. And this is called the era of the modern hospital. And they began to shift away from these large open Nightingale wards into modern towers of beds. So they were stacked. There were many floors. That was new at that time. So why is that? Because technology came in, electricity. So they had innovative ventilation methods. So they don't have to warm up in the basement, but they can use electricity for ventilation. And it's interesting to know that also bed wheels were very important, because then they could move patients to another place. And so when patients were in bed, they were not, they could not be moved to another place. And they used it also to place patients on sunny balconies to treat respiratory diseases, especially tuberculosis is a very famous one. But they also could have radiography, surgical lighting. So they had blocks of diagnostic and procedure space where patients could be transported to. So there was really a reshuffling of space, and also a new idea of what is a hospital. It's not just a ward where you were, but it's a hospital with diagnostic and procedure spaces, etc. So that gave a rethinking of the hospital design with less beds per ward, and also, again, still private rooms for isolation of infectious patients. So then the era came from 1940 to 1960. They had to speed up building new buildings, and plans were based on the pre-war thinking, 2 to 6 beds, etc. And when you have an extra bed, you have to pay for it. 1960 until 1980, then the idea of dignity and privacy came in, and also the patients and family-centered care. So privacy was definitely needed at that time. And so they built single rooms because as part of this care process and because of privacy, and not because of infection prevention at that time. And also in the 1990s in the USA, there were hospitals built with 100% single rooms. So that sounds good now, but it was not for infection prevention, but it was for increasing revenues because there were government regulations at that time. I don't know about this time, but they were prohibited to reimburse for a single room if they also had double rooms in the facility. So they made 100% single rooms, so they could always reimburse for single rooms. And at that time also there was an increased emphasis on patients' confidentiality and of course privacy still. So it is interesting to read that until that time there was no idea about infection control. So back to this Hospital Future WHO document, it says also something about single rooms, and they state, well, single rooms with flexible solutions should be favored. And there's not much about in this document about what are they thinking about flexible solutions, but maybe it is about loneliness, because loneliness is very much complained about when patients are for a long period in a single room. So you should also discuss with your architect that you need also social meeting places at the ward. So if a patient is not that ill, so they can meet each other and talk to other people to prevent loneliness. A flexible solution, whatever, what for, we definitely need help from designers. Well, I already talked about our new hospital, and we moved from 2 and 4 bed rooms to 100% single rooms, and it was a cheap intervention. So we studied this move, and we saw a dropping down, and we also published that there was a dropping down from number of acquisition of resistant bacteria in the single rooms, contamination rates of the environment, and we also noticed that the translocation of patients to other rooms, for whatever reason, decreased significantly in the new hospital. And that also means that patients were less exposed to square meters. So because when you are replaced to a new room, new chances, new environment, so new exposure, new transmissions. So that was less significantly reduced in the new building. And we also saw, and at this time still, we see the number and size of outbreaks significantly decreased. And during COVID time, we were very happy to have the single rooms because we had very low transmission rates to patients. We had a flexible conversion to contact droplet isolation already noticed because we had single patient rooms. So we did not need any cohort or whatever, and we could continue it, the non-COVID care quite, not easy in COVID time, but we could do so. And this is a systematic review. It was already published in 2016. At that time there was quite a lot of evidence that single rooms favors either colonization and also outcome bacteremia to prevent this by single rooms. So, and this is a nice paper because it addresses other things than hospital-acquired infections, because we always are focused on that item, but we also should have a view of other items on factors for single rooms. And this paper defines clinical outcomes, patient experience, and economic. And then we see blue and gray, and blue is favors, gray is neither against or pro. And you see a lot of blue and a lot of gray here for hospital-acquired infections. But when you have a view on loneliness and cost, there's less blue. So maybe we should design in a different way, or we should more studies on how to prevent these negative results of single rooms. And I think that's important also from our view. But so far, so good. In the UK, they said, well, single rooms should be the default. Wow, that's a statement. And here, I think that we need to move in our hospitals much more to single rooms. And that was said by the NHSE medical director at that time, 2021. Well, it's more than just a single room, because also the inside of the patient room is important, and we should have knowledge on that, and we should discuss every detail with architects and designer. Well, to start with, do we need curtains? No, when we have a single room, you don't need curtains. So come on, these are always contaminated, no curtains. A lid on the toilet, well, we have discussion. In the Netherlands, we say no. In the UK, I think they say yes. Well, there are other arguments. But so maybe we need more data on this. An interior window that can become opaque, so you have privacy, but you can also have a view on patients when needed without a need to open the door. The fabric and design of furniture, rooming in, it should be able to clean all this stuff here, and disinfect, of course. Storage of PPE and other equipment should be enough place for that. When you have an entry room for storage, maybe you can design it in such a way that you can convert this single room to an isolation room. So think about that. But you need also the capacity of the ventilation itself. And important, think about the position and the number of sinks and the design of the sink, of course. And to my opinion now, you don't need a sink in the patient's room, because every private room has a private bathroom. And at the private bathroom, you have the sink here in this place. So there's no need to have an extra sink in the patient room. And we are also advising this for our newly to build children rooms at this very moment. So this is the end of my talk. This is some art of our hospital. We are quite proud of our hospital. So greetings from Erasmus MC, and I'm happy to take some questions of you at the end of this meeting. Thank you very much.
Thank you, Margaret, for an excellent overview on the topic. And please, for all attendees, we have 569 participants. So keep sending those questions and we'll address them at the end of the second talk. The next presentation is on the topic of the built environment of the hospital and infection prevention, lessons of the past pandemic, prepared for the future. And who is better to give this presentation than Professor Paul Tambyah? And it's my pleasure and honor to introduce him. Professor Tambyah is Professor of Medicine at the National University of Singapore. He's a Senior Consultant Infectious Diseases Physician at the National University Health System. He's also visiting consultant at the National Center for Infectious Diseases and the Singapore Armed Forces. Professor Tambyah is immediate past president of the Asia Pacific Society of Clinical Microbiology and Infection, and also immediate past president of the International Society of Infectious Diseases. His research interests are device-associated infections and emerging infectious diseases, and he has over 450 publications in peer-reviewed journals. So, Paul, the microphone is yours. Thank you.
I'm going to be talking to you about the built environment and its relationship to the infections acquired in hospital, with some particular insights from the most recent pandemic. Now, as you know, hospitals were originally built for the poor. Many of you have visited some of the great hospitals in Europe and North America, and they all are in kind of dangerous neighborhoods. And the reason is that the wealthy used to be able to have doctors go to their homes to take care of them. And this was even the case with the last pandemic, where even in Singapore, we had people waiting long hours in emergency rooms and ending up getting infected. So this happened to us during SARS-1, when we had the majority of cases actually occurred in hospitals, either to doctors, nurses, or hospital visitors. So the question came up, after this pandemic, are hospitals safer now than before the pandemic? And this is the American Hospital Association who Margreet quoted, but I'm not so sure about that. One of the things that we realized during SARS-1 was that while healthcare workers were using PPE to protect themselves from getting infected with SARS, they did unfortunately not change gloves in between patients, and there was a paradoxical increase in MRSA acquisition rates despite the enhanced PPE precautions. So Margreet has alluded to this briefly, but I'm going to talk a little bit more from a clinical perspective as an infectious disease physician about a patient that we looked after with one of the problems she talked about. 75-year-old woman with diabetes, hypertension, ischemic heart disease, a bypass, at a Staph aureus line, dialysis line infection, treated with antibiotics, line was changed, dialysis was continued, she improved. And she was about to go home, but unfortunately, it was the Christmas and New Year season, and her whole family had gone on holiday, so she ended up staying in the hospital. Early in the new year, she spiked a fever. Her blood and peripheral and line cultures grew a gram-negative bacteria, which turned out to be Elisabethingia meningoseptica. So she was treated with a combination therapy. Her blood cultures cleared after a week. Unfortunately, a few days after that, she complained of blurring of vision. She had an examination. She was found to have an endophthalmitis, and it was the same bug that caused the endophthalmitis. She was converted to intravitreal therapy. She improved clinically. Inflammatory markers improved. She was discharged, but she's still, unfortunately, legally blind, and this was reported in the literature. We looked back, and there had been a cluster of Elisabethingia infections in the cardiothoracic intensive care unit. And in fact, there had been a lot of infections over time. So what we did was we went to the sinks. We did environmental sampling, and we found that in the ICUs, which are on the second level of our hospital, we had Elisabethingia meningosepticum in 3 of the 4 ICUs in that level. At that time, this is a few years back, before widespread whole genome sequencing, we did ERIC PCR, and we found that the environmental isolates were consistent with the patient isolates. The hand hygiene sinks, the aerators were the most guilty culprits in the neonatal ICU, cardiothoracic ICU, surgical step-down ward, and in the patient isolates as well. We finally got around to doing the whole genome sequencing, and we found out that this was actually Elisabethingia anopheles, which is actually a mosquito pathogen. And this was reported as the first outbreak of Elisabethingia anopheles in an ICU. So we talked to our contractors and we said, hey, something's going on with the sinks and the water. And they said, well, we meet the criteria, and Singapore has some of the cleanest tap water in the world. Total colony counts are way below the APHA requirements. E. coli was undetectable. But unfortunately, a lot of the sinks in these ICUs had electronic faucets. And my friend Trish Pearl in Johns Hopkins has previously shown that with the electronic faucet, what you end up getting is a stagnant column of water. So, when you put your hand on the electronic faucet, you expect the water to come out straight away. But in order for that to happen, there has to be a column of water in the faucet. And she found that when they switched to electronic faucets, the concentration of Legionella actually went up quite significantly compared to the manual faucets. So back to our hospital. So we did a case control study, and we found that the culture-positive aerators were much more commonly found in situations where there was misuse of the sinks, when people were using sinks for things that they shouldn't be using them for medical indications, for example. So we got the cleaners to start cleaning the sinks. These are manual faucets. And unfortunately, we were unable to get rid of Elisabethingia. So to this day, this is several years after the outbreak, we still have these instructions in our level 2 ICUs. Use hand rub after washing your hands, because when you wash your hands, you get Elisabethingia, and then you've got to use hand rub to get the Elisabethingia off your hands. So this was also reported by my colleague Dale Fisher and others. bad design, bad practices, and bad bugs, or the whole Swiss cheese thing, which happens so often in infection prevention. We were somewhat reassured to find out that even in Wisconsin, they've had this problem with Elizabeth Kinger, which has been difficult for them to get rid of too. So the hospital environment, as you've heard very nicely from Margreet, is a major reservoir for many different pathogens, and not just the sinks, but also dry surfaces, and even in certain conditions, the air. And this is what I'm going to talk about next. So removing sinks, again, in ICUs is possible. As Margreet pointed out, patients do need sinks for personal hygiene. So we got some way of trying to do this in a safe manner while maintaining patient comfort. We can remove water from the ICUs, but we certainly cannot remove the air. And now I'm going to be a bit controversial, but first of all, some clarifications. I love wide open, well-ventilated spaces. This is me in Mongolia. And I will wear N95 respirators and face shields if I'm asked to do so. So there's been a lot of controversy. This is more so in the last year. It seems to have somewhat died down about the last pandemic and the COVID pandemic and the role of airborne transmission in the COVID pandemic itself. And if you read the actual document, the terminology is not as drastic as the media made it out to be. So they came to this term infectious respiratory particles, and there was this concern about, the black and white demarcation between airborne and droplet transmission. And I personally thought it was a little bit confusing, but still, it's a worthwhile document to read. Soon after that, the WHO infection prevention and control guidelines were published, and they pointed out that actually there was very little evidence for a lot of these measures that were put in place, except in certain selected situations. So in our hospital, and this is again going back to the experience from SARS, we believe that SARS-1 was transmitted by the large particle, respiratory particle, as you would call it, which travels about 0.9 meters. So the beds in our emergency department were built 1.1 meters apart. And you had a patient with unexpected SARS who was in this bed, bed 19. The patient in bed 18 did not get infected because he was 1.1 meters away. But unfortunately, his wife, who was standing in between the two beds, got infected. And so that kind of is an anecdote about how proximity is important. Again, something Margreet mentioned. But this idea of disease going through the air, malaria, malaria, bad air, dominated medicine for nearly 2,000 years. This is a cartoon from America where they believed that cholera was spread by the air in the cities of the New England. And during the COVID pandemic, you must have seen this headline where 239 scientists wrote about airborne transmission. If you wonder why it's 239, I suspect that it's because I was actually asked to sign the letter, but I didn't, because I wasn't totally convinced about the importance or the overemphasis on airborne transmission. And part of the reason is, to me, airborne transmission is something like the airborne anthrax outbreak from a military microbiology lab in the Soviet Union, where the wind carried the spores 4 kilometers downwind. And in fact, 62 of the 66 infected patients were 4 kilometers downwind from the laboratory. So if you do get infected by a pathogen 4 kilometers away, then yes, I do agree that is airborne, but most of the time that doesn't happen. So some strong views have been expressed on this, and I've been in countless arguments. Early on in the pandemic, I was in the WHO guideline development group, and they used to have meetings on, I think it was Wednesday evenings, and my wife would come home and she'd say, "Are you talking about masks again?" I said, "Yes, indeed, we were." And it continued for the longest time. And this is an editorial written in one of the Lancet journals, where they gave some arguments about why they believed that airborne transmission was important for SARS-CoV-2. The first example they gave was of super spreading events. Now in Singapore, the biggest super spreading events were in the migrant worker dormitories, where you had hundreds of workers who got infected. Once we had 1 or 2 individuals infected within these dormitories. But these dormitories had large numbers of men living in very, very close conditions. And in fact, our public health people looked at the transmission, and they found that the transmission within the rooms was much, much, much higher than in the rooms downwind from the infected individuals. And so it does suggest that, ultimately, close proximity transmission seemed to be a little bit more important, even in a super spreading event. The other argument that's been brought up has been adjacent room transmission in quarantine hotels in Australia and New Zealand. And this is very unusual, where you have individuals who were in the next rooms who got infected, but other individuals who did not. And they did not test the workers in these hotels. The other one is asymptomatic transmission. Now, asymptomatic transmission is extraordinarily rare. And we know this from a large study of 10 million people in Wuhan. You can only do this kind of study in China. So they screened 9,865,404 people, and they identified 300 asymptomatic individuals, and they claimed that there was no transmission. I think there were actually 2 transmissions. Most of the transmission that has been classified as asymptomatic in COVID has actually been pre-symptomatic, the day before the onset of symptoms, which is very similar to influenza or varicella, for example. The other argument that outdoor transmission may be less than indoor, and again, this goes both ways, I think, for both whether it's close contact or airborne transmission. Infection occurs despite some PPE, and this one I agree with, where you've got aerosol generating procedures where you have high dispersal of particles and the risk of transmission. And this has been shown in multiple occasions. This was shown in the United States. It was also shown in Singapore. Now, this is one that upsets me a little bit, is this argument that just because you find the virus in the air, so that suggests that it's infectious. And there was a study published in the New England Journal early in the pandemic, which suggested that high doses of infectious virus could be found in aerosols. But I always tell my students, you have to read the fine print. And you'll realize that the virus particles, this was in an experimental situation where the virus particles were dispersed using a high-powered nebulizer. And there was a drum that was used to detect bioterrorism agents. So it's very sensitive. And that was the means by which this was detected. In contrast, in real life, my colleagues at the National Center for Infectious Diseases were unable to find live virus in the environment. And similarly, we could not find live virus in the environment either in our university hospital. We collaborated with Don Milton and his team, who built this amazing apparatus, the G2, and we had people breathing, talking, and singing into this device, and still were unable to find live virus. And finally, you had this study done in Florida, where they did isolate live virus, but intriguingly enough, they isolated live virus from the environment at a time that the patient himself was negative for the virus. I would argue, though, that finding live virus in the air does not equate to transmission. And in fact, way back early in the HIV epidemic, you find actually live HIV virus was detected in the vapors of surgical instruments. And of course, nobody believes that airborne transmission of HIV occurs. Similarly, this argument about detection of RNA in the building ducts and filters, I think, is not totally convincing. Animal studies in separate cages. And again, if you study these papers that are cited as evidence for this, you'll see it's similar to the aerosol transmission studies, where these are very specialized experimental designs. Maybe airborne transmission depends on individual shedding, and this is certainly possible, as we know from the infection control literature about the cloud adult, who may be an MRSA disperser, which is, again, something that people argue about. So there were very unusual airborne transmission events which were described. This is from Australia, where you had an organist who was infected, and then the only people infected were people from the same family sitting in the same few families sitting in the same row. So again, that's a bit difficult to justify. And finally, limited evidence of other routes of transmission. Now, again, going back to the early days of the Singapore outbreak, this was a very unusual workup that was done and published in the Lancet Infectious Diseases, where they showed that a couple had been to a church and they were captured on CCTV Don't ask me why they had CCTV in the church. And then subsequently, another couple who were sitting in the same seats but no physical contact on the CCTV ended up getting infected. And that's, again, another hugely controversial issue. But if you leave SARS-CoV-2 and you go back to the previous pandemic with the H1N1 2009 and even seasonal influenza, you have this large randomized trial done by Ben Cowling and colleagues. And you see that actually face masks did not add anything to hand hygiene in terms of prevention of influenza transmission in households. And it's also important to be aware of unintended consequences. So this is a 48-year-old man we looked after, intubated for MICU for hemodialysis initiation as he was in fluid overload. He responded well. However, he desaturated, had to be re-intubated, had a BAL done. And as you can see, his X-ray got a lot worse despite the hemodialysis. His BL ended up growing Aspergillus. Aspergillus fumigatus, his galactomannan index in the BL was very high. An alert MICU nurse manager looked back and realized that there had been a huge number of Aspergillus cases in the ICU at the time. And then we realized that construction actually is endemic in Singapore, and there had been some construction outside of the ICU. Now that ICU was rebuilt after SARS-1, and the way it was built was that every single room was a negative pressure room. So unfortunately, when you've got construction outside the ICU, when every room is a negative pressure room, it sucks in all the fungal spores outside in the construction setting. And even though we have policies in place to try and reduce the dispersal of spores during construction, these are not always consistently followed. And this is in our hospital where the contractors are trying to put up a sheet, but I always take pictures of these and send them to our environmental services, so they really don't like me. But I'm just trying to point out that just because we have a policy doesn't mean that people are following it properly. And of course, when we did air sampling, we found Aspergillus all over the ICU. So now we're stuck. The whole ICU's got negative pressure rooms. Do we renovate the entire unit, put in portable HEPA filters, ban or transplant our hem-onc patients? In the end, what we did was what our neighbors down the road at Singapore General did, which was to put in high HEPA filters in the rooms. They showed that it does reduce invasive aspergillosis. They're very noisy. They take up space. Not a good solution. Much better would be what Margreet suggested when you're designing the hospital to think about how to use, build the rooms. So in summary, what did we learn from the pandemic? Okay, I think we learned a lot. We may have learned some of the right things and some of the wrong things. I think what's important is to resist the temptation to impose top-down rules, the evidence for which is maybe lacking. We need to focus on what works. And this is my arm. During the Mpox panic, I roll up my sleeve and I show them that I've actually had 2 smallpox vaccinations. And so I ended up getting volunteered early in the days when they needed some infectious disease person. And then maybe we can think about ventilation. So that's all I have for you today. Please feel free to ask some questions. If not, you can always email me. And if you do want to come to Singapore next month, there's a good meeting you can come for too. Thank you.
Thank you very much, Paul. That was a brilliant presentation. And for some who are asking in the audience, this webinar is going to be taped and you will have access to the material soon after the end of the webinar. And we have 22 questions. We have 540 participants remaining with us. We had over 565 at some point during the webinar. So this is a great turnaround and really reflects the interest in the topic and the enthusiasm people have for when they see speakers such as Margreet and Paul being in a symposium. So I'm going to pass on the microphone to Robert and we will be alternating taking questions. We already have a lot of questions in the Q&A box. Robert, please.
Yeah, so thank you very much, Souha. And first of all, thank you, Paul, for this excellent talk. And yeah, as you said, the controversy about how this is spreading airborne or not, that will maintain for quite some time, I think. So it's really nice to have this revisited. So I will start taking up a couple of questions that has come in. And one of them I actually think was a bit interesting, and also to hear from both of you, is could you please summarize the pros and cons for having sinks in a patient room? Would you start, Greg?
Yes, thank you. I think we can have both words on that. Well, it depends. There is no single solution for that, because it depends also whether you have single rooms with private bathrooms or single rooms with shared bathrooms, etc. Well, the most easy one is that you have single rooms with private bathrooms. So for each patient, their own bathroom. And then you can make a choice that in the bathroom, of course, there's a sink for personal care. And so you can decide on no sink in the patient room, because in case of when you use because of material on your hands, organic bacteria or an alcohol-resistant microorganism, you can use the sink at the bathroom. But then you have to enter with your dirty hands from the patient room to the bathroom. And so you also need an automatic door. So resolve it together with your designers, but touchless, something touchless, no by kicking the door because that makes sounds, etc. So resolve that problem. So you always have to think what's coming next from one solution. But that's the most easy one. So an automatic door I use in case if you need water and soap, you go to the private bathroom. When you have shared bathroom, it's more difficult because then you have to decide on what is in the case that that nurses and doctors need water inside, and what about the patients themselves. And so you have to decide on that and balancing this with the risk that actually sharing bathrooms, sharing sinks, the chance that they are contaminated is even higher. So that is also, so if you can choose, take the one, and they say, well, it's high cost. They say, well, in the end, not, because when you prevent infections, these are lower cost for altogether. But, maybe Paul, you have to say something as well about things in the patient room. Yeah.
I mean, ideally, we should have single rooms, but in real life, especially, I noticed some questions from LMICs where that's just not going to happen. And in Singapore, in public hospitals, we have 6-bedded cubicles, and we have shared bathrooms. So that's been hugely challenging. One of our secondary hospitals actually came up with a really bright idea where they have UVC, and they have an automatic door. And so when there's nobody in the bathroom, the UV light comes on. And then the minute somebody gets into the bathroom, the UV light is turned off for the shared bathroom. So they claim that that's actually reduced the CRE transmission, which they think was associated with the shared bathroom. But I've asked them to actually try, doing some microbiological sampling and to compare the data. In our ICUs, as I mentioned, we had a really hard time, and I think it relates to the temperature and humidity in Singapore, because Singapore is just talking about what it is in Europe right now. In Singapore, it's all the time, and it's all very humid. Now with all these sustainability measures and reduce the air conditioning, it's very, very hard to control the humidity. So we're trying to move sinks out of the ICUs, or at least the patient areas in the ICUs, tough areas. And that's what we're trying to do over.
Yeah. So can I take a follow-up, which also came, and this is, given that you have, at least in Denmark, you have, well, let's say 2-bed or 3 bedrooms, and you have one sink often close to the door. Is there a recommendation on how far should the patient beds be from the sink if you have to have a sink inside, or if you do have a sink inside a room?
Well, shall I start again as the first one? Well, there is no real recommendation, but there are some papers now, and there's one paper that says 1 meter. There are papers that say 1.5 meters. and it also depends on droplet distance transmission. But I think 1.5 meter is a good one. And then it's not from the patient, but the storage of clean material used for care is also included. So the 1.5 meter is around the sink where anything comes which is used for care. So I think so far so good, 1.5 meter, but it's not recommendation level A. I think it will never be in that way. And I want to say some words about the ICU. I really agree that in the ICU, when a patient is an ICU patient, there is no need for a sink there. But we are now going to build ICU for children, and we have rooming in at the ICU, and then you need a private bathroom for the parents as well. So then again, you have an annex bathroom at the ICU, and there is the water and water supply, and then for the personal care as well. So that resolves also the problem when you have dirty hands. When you are in the ICU with dirty hands and there's no rooming in and there's no sink, then you should know your way how to go out that patient room and where is then the next sink where you can clean your hands. So really in the design altogether of the word, you really should think and you should imagine what will happen when this happens. Where are you going? Can I go outside without touching? Is it a long distance? There's also a nice paper, I don't know which author, and it immediately has a correlation between the distance of the sink and the use of the sink. So it's quite interesting to keep this in mind also. So it's not just no sinks and that is. So you should really think about the process of care, whether it's safe.
Yeah, I would agree with the.
Yeah.
Sorry.
No, go ahead, Paul.
Please, Paul.
Yeah, I would agree with the 1 to 1.5 is. But one of the things that we recognize is also the training of the staff, because what we found in these outbreaks was that people using the sinks for things that they were not supposed to use them for, like for instance suction catheters or equipment going to be used with the patient. So in audits and reinforcing this was almost as important as the physical location, and much easier to do rather than just trying to move a sink over.
Thank you, Paul and Margaret. So there is a question from an anonymous, and I guess the answer would be dependent on which pathogen we're talking about, but they're asking if a hospital ward is left empty for a while, would multi-drug resistant bacteria disappear? And can rotation of wards be an option if there was sufficient capacity and the opportunity to move patients to another building? Paul, perhaps you can start with this one.
Yeah, so I'm going to start with a topical perspective. And I can tell you, when we leave anything empty for a while, it's invariably covered with aspergillus, with mold, and so with bacteria, possibly, we see some of these environmental gram-negative bacteria there, but it's just the humidity and the heat which are very conducive to mold proliferation in tropical environments. So if we leave room empty, we try and do something like UV or HPV or something to try and disinfect it before we're going to use it again.
Thank you, Paul. So Margaret, a question about in low-income countries.
Can I address the question of leaving the ward for a while also?
Yeah, please, go ahead.
Yeah, because you were talking about aspergillus, I fully agree with that, but also the gram-negatives in the drains, they are in a thick biofilm. So if you leave the ward and you don't use the water tap, it doesn't mean that the gram-negatives will die, I think they will stay wait for the time they can be transmitted again. So I think that's not a solution. in its way to leave the ward and come back to it like a rotation of using wards. I don't think that's wise. Gram negatives and biofilm will, and you also have the dry biofilm. That's why there is a biofilm, that they can survive. So they laugh about it, the microorganisms. That's my idea. I have no scientific data, of course, but we all know that for several months microorganisms can stay, especially in drains and sinks and dishes with dust.
Yeah,
But you had another question, sorry.
yeah, no, I think we want to try to get to all the questions if possible. But so there's a question from Precious on in low income countries where you can't have a budget to modify structural designs. So I give one example. We had a problem with Pseudomonas aeruginosa water contamination in a high risk unit. And so the question is, are there alternatives that you could do to try to control the outbreak? Perhaps if we take the example of one pathogen, such as difficult to treat Pseudomonas.
For me, yeah. It's difficult because it depends on the configuration of the ward, but you can take into account the distance we already discussed from sinks, because everywhere where it's wet there are microorganisms. You can take into account the furniture, the material, easy to clean, etc. You can take into account sharing items, so from one bed to the other, that you realize what you bring from one patient to the other. You can take into account, of course, hand hygiene. So these are less costly than changing the ward configuration. You can also think about using PPE as the example you gave in the start of your talk, Paul, about that PPE is not changed between patients because of the situation, and at that time it was COVID. So maybe you can consider these very basic infection control next to try to have even the design changed of the ward, because that's costly, of course. Yes, sure.
So I can continue with one of them that is coming and say that is there any specific advice for emergency departments? I guess it's because of the high turnover of patients and staff there. So is there any specific considerations building emergency departments that people should think of? Any of you who has a point
Paul,
of
you
view?
have
we
a separate emergency, yes.
yeah, we try and keep it as far away from the rest of the hospital as we can.
Yeah.
That's one of the things that we try and do. And so the hospitals right now, it's like a major travel hub. So there's a bit of panic of people coming in with hemorrhagic fevers and things like that. So one of the things is actually separating the emergency department. One of the other things that we do recognize is hygiene compliance rate always the lowest in the emergency department, because we're so busy trying to resuscitate patients. You really have you don't pay attention to hand hygiene. So we try and make it as conducive as possible to hand hygiene in terms of the construction, but it's not always the. Over to you, Margreet.
Yes, I can say some words. Of course, it depends on your population. But one particular interesting thing is the short stay because of observation. Because when you are in an emergency department, you are being observed, and sometimes it's not clear whether you can go home, back, or you will be admitted. And so it's the in-between patients. And they are mostly put together at the emergency department to wait for 24 hours which direction it will go. And that is quite, well, for me, I don't like that at all, because they are put together. They are, well, intensive care, of course, they need. They can deteriorate or whatever. And they are close together. And when you have another microorganism like MRSA or Furey, well, that's the solution to have an outbreak, because one patient is orthopedics, goes to the M1 department, the other goes to the ICU, and the next goes to internal medicine. And so you have a spread from like a hub at the emergency department. And I have to confess, we do have in our new hospital a 4-bed short stay observation units, and I always wait for the outbreak which started all over there. So that is my comment on the emergency department, which is, you have to think about it. Do you like this? Can it be another way organized? So maybe to take into account.
Then one more question is, could you please comment on the role of CO2 monitors as a proxy for ventilation? Paul, will you take that or start that?
Yes, CO2 monitors are very popular. You know, they're now being marketed in many hospitals in Singapore. And you know, I've seen, you know, how they correlate with like air changes, for example. But I think there are many issues with the CO2 monitors, in particular with how you place them. And I'm afraid that they might give you a false sense of security in terms of the handling. And we're not talking here about negative pressure or positive pressure rooms, but we're talking about rooms which, you know, after a while, the patients tell you this room is really stuffy. And the concern is that when you do get, because we still get cases of tuberculosis, and now we have a resurgence of measles, which are diseases which are well known and well documented to be transmitted by distances. So I am a bit skeptical. There is emerging data about CO2 monitors, and I will be convinced if I see more convincing data. But I do know that they are being widely used, so I'm looking forward to seeing data. Over.
Over to you, Souha.
Yeah, thank you, Robert. So there's a question from Rashka to either one, Paul or Margaret. Is the persistence of pathogens on high-touch surfaces a greater risk than hand hygiene non-compliance? And are we focusing on the wrong intervention?
Well, I think both are bad. I mean, in fact, we have a scheme. We've just written it up, actually. I think where, you know, we use electronics for everything. So the officers, the junior doctors, they spend more time on the computer than with the patient. And what we've done is we've computer to time out unless they use hand hygiene. So you can't do one without the other. You know, you can't. If you have surfaces which are heavily contaminated, you know, then obviously you need to clean them. But at the same time, that's not an excuse for dropping off on the hand. So I think both are important. Agree?
Yes, I agree, Paul, because it's both important that you have a clean environment, clean surfaces around the patient, and also have a high compliance on hand hygiene. I think it's especially important to teach the nurses and the medical doctors what is the one of the 5 moments of hand hygiene, touching the environment. What exactly is the environment? So maybe that is important to pay attention to that. Is it the immediate patient environment? Is it whatever? Is it also the table or the chair? And so you have to decide on this is touching the environment, and then you go to the hand alcohol, irrespective whether you know whether this surface is contaminated, because you cannot know all the time. And of course, when you have a persistent source of a contaminated item or surface in your room, well, there is one time it will go wrong, of course, because then there will be a transmission, either by touching of the patients themselves or by touching the hands of nurses and doctors. So I think both is important, and it's also important to focus on cleaning and disinfection, and doing audits, and maybe sampling the environment, which is another issue, very important and difficult, how to sample the environment. And we are now focusing on a guideline together with the HIS and the ESCMID, a new guideline how to sample the environment and to interpret the results of it. So it will come. I don't say soon, but it will come.
Yeah. Thank you, Margaret. I guess in 2025, we can't have a webinar without asking a question related to emerging technologies and artificial intelligence. And the question is, do you see emerging technologies such as smart ventilation systems, antimicrobial surfaces, or real-time environmental monitoring coming our way and playing a role in hospital prevention over the next decade? Is this coming up, the new technology, or we're still too far away from that?
Well, let me start. I've been involved in the environmental surface for 25 years, and frankly, nothing really seems to have worked. There was a lot of interest in copper. I've looked at silver on urinary catheters, and just basically, it's always very attractive, and I'm very excited when my engineering colleagues are thinking of something, but so far I haven't been convinced. What I do think has changed is this whole idea of medicine. We're moving more patients out of the hospital. So this whole issue of healthcare-acquired infections is going to go away if the patient is in their home environment, and they're providing a lot of the care. I just had a patient who was trying to decide on a pacemaker, and he had an Apple Watch. And so he was able to generate his ECG for the last 48 hours. And that is something that could not have been done 5 years ago. So I think, to me, the biggest advantage of the new technology has got to be moving patients out of hospital and going into a situation where they have more control. There's a lot more that's done in the patient's own environment, and that you're not introducing more opportunities for cross-contamination over.
Margaret, any additional thoughts?
Yes, I fully agree, because when you are at your home microbiome, like the environmental microbiome, it's always better than the hospital microbiome. And so maybe that's one of the solutions, a short stay. And now, up until now, we are just cleaning and disinfecting by hands, with just using alcohol, chlorine, and microfiber. So we are doing dry cleaning, and it's okay for so far so good. So we don't need UVC robots, etc. But of course, maybe in some instances, or some situations, it can be helpful as an additional thing. But we should never move away from just cleaning and disinfect by hands, and having a good ventilation, especially when needed in isolation rooms. So nothing more to say. Maybe a bit conservative, but we still see all the ideas, and we still don't need it so far. And basic measures are there.
Thank you very much. I'd like to really thank both fantastic speakers on the topic. I'm going to leave it to Robert to say the concluding remarks, and just to read that certificate will be shared a few days after the event, and Fee put the link to have access to the recording of this webinar. And here I'd like, before I pass the microphone to Robert, to really thank Fee Johnston for organizing the webinar and for her fantastic communication. Robert, the microphone is yours.
Thank you very much, Souha. So even good things and exciting things has to end at some point. And we really would like to thank both Paul and Gret for really excellent and thought-provoking speeches here, but also you as the audience for putting in so really interesting questions. And apologies for you who posed questions that we did not reach, but I really think that this year has been a fantastic webinar. I also, of course, would like to thank you, Souha, for co-chairing and actually for ISAC to organizing this really great and important webinar here. This year is a topic that is very, very difficult, as we could hear, but it's somehow very often missed or overlooked. So it was really a great, great pleasure to be able to co-organize this webinar together with ISAC. So thank you very much, all of you, for participating. Thanks again to the speakers, and thank you to ISAC. Thank you very much, all of you, and have a great day.